Good afternoon, everyone. My name is Yasmina Sisrak, and I'm your host for today's webinar. Thank you for joining us for our COVID-19 webinar series presented by the HealthMatters program at the University of Illinois at Chicago through continued partnership with Project Search and their funding from the Ohio Developmental Disabilities Council in collaboration with Aspire Community Services in Illinois. We have added a summer webinar series to provide a space for community providers to share their experiences and resources in maintaining services for people with intellectual and developmental disabilities during the COVID-19 pandemic. The situation keeps changing, so we try to keep up and update you as people are learning new things. These webinars will be recorded and archived, and then you will be emailed once the webinar has been archived, and we're trying to get that done within a week of the webinar. During the webinar, please note your questions in the chat box, and we will ask these questions during the last 15 minutes of the webinars. So for today's presentation, impact of COVID-19 on organizations serving individuals with intellectual and developmental disabilities, we are delighted to have Donna Martin joining us. Donna Martin has worked in the field of providing supports and services to people with developmental disabilities for over 30 years. Most recently, Donna has been serving as the Executive Director of Community Provider Network of Rhode Island for the past 14 years. Donna is a longstanding member of ANCOR and most recently has served as the State Association Executive Representative to the Board of Directors. Today's presentation will provide an overview of the April 2020 American Network of Community Options and Resources, also known as ANCOR survey, results documenting the impact of the COVID-19 pandemic on their members. Again, we are recording this webinar, and we will make the presentation and the resources available after. Ask your questions in a text box. I will be collecting them. Everyone is muted except Donna and myself. And again, thank you again for joining us today. Donna, welcome.
Thank you, Yasmina, and thank you everyone for your interest in this subject. I did want to add, well, thank you, Yasmina, for the introduction. I think I sent you an older bio because I am currently the Director for State Partnerships and Special Projects and am on staff with ANCOR.
Oh, I'm so sorry, Donna.
No, that's quite all right. No worries. I'm very proud of the work that I did in Rhode Island. Today we're going to be talking about a survey that ANCOR developed for our membership to evaluate the early impacts of the coronavirus on the service providers in our membership and beyond. What I'd like to do is give you a little background on who we are and what the impetus for this survey was. Let's see, I just hit a wrong button, and here we go. So ANCOR is the American Network of Community Options and Resources. We are a national nonprofit trade association that represents more than 1,600 private community providers of services to people with intellectual and developmental disabilities and autism. Combined, our members support over 1 million individuals with individuals with disabilities, and we work to shape policy, share resources, and strengthen this community. Our mission is to advance the ability of our members in supporting people with IDD to fully participate in their communities. And our strategic priorities include influencing responsible federal public policy to protect and promote quality service, obtaining resources to attract, expand, and retain a quality workforce, and being an invaluable resource to equip providers and partners in understanding and responding to impacts, opportunities, emergency practices and trends, and shaping the future of service delivery models and measures to ensure sustainable service. So a little bit of background about what has been happening as it pertains to the IDD community during the early weeks of this pandemic. So on March 1st, ANCOR held its first member briefing about what was emerging as this pandemic that we know as COVID-19. We included speakers from the American Academy of Developmental Medicine and Dentistry. We had 2 physicians with that organization. We had a registered nurse from the Developmental Disabilities Nursing Association, and they are a national association with state chapters that focuses on the specific needs of serving individuals with IDD. And we also had representatives from the National Association of State Developmental Disability Directors for Services, NASDs. During this briefing, the physicians talked about what we knew at the time on March 4th, shared with our members what we were learning, what was expected, what we anticipated. The nurse from DDNA talked specifically about safeguards and precautions as it pertained to our services, many of which have been delivered in congregate settings. And from NASDs, that organization supports the state DD directors. And so they shared with our members the resources and guidance that they were providing to the state programs. On March 1st, Congress passed the Coronavirus Preparedness and Response Supplemental Appropriations Act, and the provisions within that act, among other things, provided the small business disaster loans and funding for emergency telehealth services. And that was really interesting because telehealth had, up until this point, not been widely used in the IDD sector. And now that is pretty much a prevailing practice, and we're starting to see states pass legislation and implement policies that will extend that practice far beyond the lifespan of the pandemic. On March 16th, we held our second member briefing, and this one focused on the states of Oregon and Washington. And as you remember, those were the states that were early in this country with regard to incidents of the coronavirus. And so we had people from our 2 state associations sharing with our colleagues what they were seeing and experiencing, how they were adapting their services to keep people safe and healthy, and what kinds of guidance and support were they getting from their state partners. On March 18th, Congress passed the Families First Coronavirus Response Act. Some of the provisions included there were the Emergency Family Medical Leave Expansion Act, Emergency Sick Leave, and a 6.2% FMAP increase to the states. Now, for those of you who might not be familiar with that process, the FMAP is the Federal Medicaid Assistance Percentage, and it is a calculation that determines what contribution the feds provide to each state in support of their Medicaid program. And the formula is based on the average per capita income of the state. So the lower the average of the per capita income, the greater percentage of funding the feds provide. So when this act allocated a 6.2 FMAP increase, it was on top of the state's existing federal support. So it sounds like a great thing, and it is, but just because these funds are Medicaid, because the funds come from Medicaid, often in times like these, states simply add it to their general revenue, which is permissible to do so as long as the state ensures its maintenance of effort with regard to Medicaid eligibility, the populations they currently serve, and the benefits that they currently offer. What it does not ensure, or did not ensure in this case, was that the Medicaid-funded services would see any of these dollars. Some of the states honored the Medicaid programs, like the state of Washington, used the funds to support provider organizations with things like enhanced provider rates, enhanced funding rates, enhanced funds for PPEs and such. And actually just a week or so ago, the Pennsylvania legislature appropriated a portion of their FMAP increase to IDD providers to help offset the financial burden of the pandemic. But most states simply add the funds to the general revenue in anticipation of significant revenue shortfalls and budget deficits. And another element in that relief package was the tax credits for paid sick and family leave and medical leave. And then on March 27th, as you all know, Congress passed the CARES Act. Major provisions included $500 billion additional and small business disaster loans, funding to the states for extended or enhanced unemployment benefits, and $100 billion to the states via direct contribution. And this was big and different from the FMAP increase in the previous package. A portion of the dollars in this act were allocated directly for states relief. And then there was the Public Health and Social Services Emergency Fund that provided approximately $100 billion and was directed by Congress to flow to Medicaid and Medicare providers directly from HHS. So they were dollars to support those programs that were not actually Medicaid or Medicare dollars. And so when all this was happening, we at ANCOR anticipated early to mid-March that we knew there was going to be a third relief package. We knew that was in development and that it would focus on relief to states. And we were hearing that there was going to be a fourth package. We knew that we needed data and not just stories that we were hearing from our members to support our ask for fiscal assistance and relief. So that is what really was the backdrop to the rationale for our service. As we all know, services for people with IDD and autism have been struggling for many years. We struggle to maintain stable funding. We struggle to recruit and retain a stable workforce. We struggle to keep pace with inflation and the general cost of doing business. And with the explosion of COVID-19, we were anticipating a deep impact on our already fragile system. So we started this project to try to quantify the impact and illustrate the need for additional state and federal support. We wanted to inform Congress about the need for funding from the CARES Act, which, as I mentioned, allocated $100 billion in the Public Health and Social Service Emergency Fund. And we were, as I mentioned, anticipating a fourth package. So we started the project to try to quantify the impact. We were already hearing about extreme shortages of PPEs among our members, and we were already experiencing serious staffing shortages, people having to take time off to be with family, or because their children were no longer in school. We were hearing about cost overruns due to excessive overtime, and the need to incentivize and compensate staff for working in potential infectious environments. We knew we needed to define and validate the stories we were hearing from our members on the ground. So as we started to look at our survey development, we established an advisory group of staff and members and recruited an individual we knew with a demonstrated research experience. We determined what the key metrics would be, and those were really drawn from the stories we were already hearing from members. They were related to the closure of lines of service, whether those were mandated by the state or otherwise, and what was the related impact on the organization's revenue. What were the atypical expenses? How was COVID-19 driving up provider costs? And with regard to cash on hand, how long could providers sustain operations with reduced revenue and increased costs? As I mentioned earlier, we know these organizations, whether for-profit or nonprofit, typically have extremely small margins. They typically do not have lots of liquid assets. And so we were hearing organizations express extreme concern over their ability to continue operating. So we developed our questions to try to solicit member experience on these metrics. We vetted the survey questions to ensure they would capture what we were suspecting were the most relevant experiences of members. And we used our broad electronic distribution list to reach all of our members. So to the survey process, we of course were targeting our member organizations, but we recognized that this issue was much bigger than just our members. So we worked in conjunction with our state associations, asking them to share the survey through their membership. And a point of note here is that we have 54 associations across 48 or 47 states. And most of those associations have members that are not also our members, and we wanted to cast as broad a net as possible. So we worked pretty aggressively with our state associations to reach out to their membership broadly. We knew that the information that would be gathered would be important across the system and would certainly be critical to the sustainability of the service system. So the survey was conducted between April 6th and 10th, and we were seeking to capture highly relevant experience at the point of service. So we kept the window of data collection very small. And I'm happy to say we received responses from all 50 states and DC.
Donna?
Yes?
You're going in and out. So if you can get the speaker like as close as possible, so we're kind of, if you can just tell a couple of last sentences again, that would be great.
Sure. Is this any better?
Yes. Thank you.
Okay. No problem. So as I was saying, we worked with our state associations to get the survey out to as many service providers as possible. We looked beyond the borders of our membership to do so. The survey was conducted between April 6th to the 10th because we were seeking to capture as relevant and current information at the point of service as we could. We kept the survey window pretty small. And we received responses from all 50 states, including DC and the U.S. territories of Puerto Rico and Guam. So we were really excited to get such a broad-based response. Once we received that data, our consultants did an initial scrub to eliminate duplicates and those kinds of issues. And then we...
Donna?
Yes?
It's still very hard to hear.
Okay. Let me see.
It goes really far out, and it's really inaudible.
Is this better?
Yes.
Okay. I just switched my my speaker. I'm sorry about that, folks.
Yeah, it's much better. Yes, thank you.
All right, we're going to try this again. Is that better?
Yes.
Oh, perfect. Okay. My apologies, everyone. So once we had really sort of scrubbed the data and looked for a first run, we looked at eliminating any duplication of data entry points and such. We then sent the raw data to the organization called Avalier. And at the beginning of the process, we recognized the need for an independent analysis of the survey results to bolster its credibility. And so we decided to work with Avalier. And they are a consulting firm located in DC, and they focus on analytics and improving healthcare services generally. So they certainly understood the lane in which we operate and have demonstrated experience on these types of projects. So Avalier completed the analysis of our data, determined that of our original 715 responses, 689 were valid. And they used that as the total sample. So that was, we had about a 43% response rate. Once drafted by Avalier, our internal team reviewed the analysis for clarity and follow-up questions, and then Avalier finalized the report for distribution. So what did we learn? So what we learned, now let me back up. So what we have here is just sort of an overview of our responses. As I mentioned, Avaleo determined that 689 responses were valid. And for this survey, we set the breakpoint between small and large organizations at 200 employees. And so of our respondents, 67% were considered a small organization employing less than 200, and 33% were considered large. In hindsight, we probably would have set that breakpoint at 500 so that it would align with the PPE eligibility, the PPP loan program eligibility. It would have been interesting to kind of see that breakout, but these decisions were made prior to that. So that's how our distribution broke out. And just a note, as you can see on the slide, the 698 responses represent over 240,000 direct support professionals working in the field. So as I had mentioned, we had several metrics that we wanted to evaluate, the first being the number of program closures. We asked if organizations had closed any of their service lines, either because the state had mandated the closure or because the organization did so in an abundance of caution, or because it was simply not tenable to maintain operations. So from the data, what you can see here is that 68% of the respondents reported that at least one program had closed. So it was 68 of all respondents to this question. 63% fell into the small organization category, and 78% of the large organizations responded that they had at least one program closure. What I want to point out is that a greater percentage of the large organizations reported closures. On the surface, that might seem counterintuitive, but in all likelihood, it is related to the fact that larger organizations tend to offer more diverse service lines that would have had exposure. For example, a lot of the smaller agencies may only provide residential or host home services, and those cannot be closed or furloughed, versus the large organizations that may be more likely to offer employment services, community-based day services, and transportation. And we know anecdotally that it is those programs that saw the greatest number of closures. Another point of note is that of those 468 respondents, they reported an average of 3 program closures as a result of COVID-19. And the breakdown, as you can see here on the screen, 54% reported day service closures, 31% reported supported employment closures, and 19 reported transportation closures. Second, but a related measure here is lost revenue. As you can see, of the 68% of organizations reporting having closed any programs or service lines, for those 468 individual organizations, this represents a loss of 32% of their annual revenue. So of particular concern here is whether or not these programs and organizations, especially the small ones, will be able to rebound post-pandemic. And we're concerned that we may see a permanent contraction in the community-based system, which will affect access and infrastructure to support the services that people say they need and want.
Donna?
Yes?
Can you define again small versus large organizations?
Yes.
Just for clarity, a couple of people are asking.
Of course.
And then one more question. Did you split the data between rural and suburban urban?
That's a great question. We did not split the data out geographically. But the break point between the small and large was 200 employees. So small organizations had up to 200 employees, and large organization, and we classified one as a large organization if they had more than 200 employees. But we did not break it out geographically. So moving on to the next metric, this is looking at additional costs. Now, what I want to preface this with is that all of these cost centers are typical expenses that our members incur, but we wanted to understand if they were experiencing an increase due to the pandemic. So let's break it down. The first element of cost here is with regard to overtime. So on this question, all responded, and 52% of the respondents said that they have incurred overtime in excess of average overtime expenses. So generally, these organizations run a fair amount of overtime due to ongoing workforce shortages. And we know from prior studies that the organizations run between 16 and 20% long-term staff vacancy rate. So in other words, that's somewhere in the range of 1 in 5 regular staff positions go chronically unfilled due to difficulty with recruitment and retention of staff. So if you think about it in that context, these organizations have a baseline of overtime. And of the respondents, 52% reported having excess overtime due to the pandemic. And what the data demonstrated was that on average, it was costing those organizations an additional $77,000 per month. The second element we looked at was with regard to onboarding, and we asked this question broadly and included elements of onboarding like background checks, initial training, and such. But we specifically wanted to know about atypical expenses for PPEs and other related supplies. And here, 21% said that they had onboarding costs in addition to their regular typical expenditures, and that those averaged about $28,000 a month. And then the third component was with regard to training cost increases. And those related to a few different factors, including having to do either additional sessions to account for social distancing practices, like they couldn't get as many people in a class at once, so they had to offer multiple sessions of the same program, or perhaps having to convert their training systems and processes to virtual platforms, and for some adding or enhancing learning management systems that they may have already had in place. And the 20% of respondents that said they did incur additional costs was at an average of about $16,000 per month. So then the fourth metric that we wanted to try to understand, because we had been hearing this anecdotally, was with regard to organizations' available cash on hand. Now, we specifically asked them what they had on hand, available liquid assets that they could draw upon to help them weather the pandemic. You can see on this slide that 87% responded that they did have, that they had cash on hand as a percent of revenue, 87%, so they had an average of 10% of their annual revenue available to manage lost revenue and increased pandemic expenses. So when we looked at what was their total operating revenue reported, what was their cash on hand reported, it averaged out to be only about 10%. So as we're looking at lost revenue increased expenditures, and having very little liquid assets to draw upon, the respondents said that they had an average of about 6 weeks of cash to manage operations. And from the respondents, 55% said that they would not be able to continue operations beyond that threshold without some fiscal relief. And Avalier determined that the combination of lost revenue and increased COVID-related expenses equaled about 40% of revenue for these organizations. So in summary, these organizations have been and continue to operate on the brink. They're small, some are large, some are for-profit, some are nonprofit, but many have been operating with decade-old rates that have not kept pace with inflation. And they all operate with significant staffing shortages, and they all struggle to hire and keep staff. Yet they have been the first line of defense in trying to keep a vulnerable population safe and out of more costly emergency centers and hospitals. We're going to feel the impact of this pandemic for a long time to come. And we know many states are already facing significant budget shortfalls for the current and the coming year, and health and human service budgets are always ripe to be cut. But we also know that this will be a time for great change in how we provide services to this sector of American citizens and how those services are funded. Thank you, and I'm happy to take questions. I also want to note that the full report is available at our website at ANCOR.org. It is on our landing page, and I would also encourage you to also look at our Forgotten Faces campaign, which is also on the landing page of our website. And Yasmina, I'm happy to take any questions that people may have.
Thank you so much, Donna. Please put in your questions in the question and answer or chat box. There is one question that came through. Were providers allowed to provide bill for day services during home lockdown? Do you know that? I can tell you that that varied across states. So many of the states initiated practices where people could use virtual support or some virtual job coaching support or some virtual sort of like social and community-based activities. Some states offered retainer payments for these services that were closed to try to help keep the organizations whole. Part of the problem we have been facing with that is that CMS has said that they are unable to pay for a service not provided, and therefore states could not use Medicaid funds. There is some dispute about that that is trying to be sorted out, but for those states that did pay retainer or hazard kinds of subsidies for organizations, that primarily came out of state funding. And for those organizations that were able to provide even some reduced service, were able to bill. So it really varies state by state. And we do have a separate report about that. If the person who's asking would like more information, they can contact me via email. Thank you. Did the providers say what their highest cost has been during COVID-19? The highest costs, I think, have been around overtime expenses, and then many organizations have offered enhanced wages for their staff. In many cases, they did not receive any supplemental funding for that. So whether it was an enhanced hourly rate, I know some paid stipends for staff who were willing to quarantine with the individuals they support. Others were offering sort of a flat bonus,
or a differential if a staff person was working with someone who had tested positive for the virus. So many organizations, handled it in different and creative ways.
Another question, how severe is going to be the long-term impact of the crisis? And if agencies close, what will happen to the consumers?
Yeah, that's a really good question. I don't have clear data yet on if organizations have actually shut their doors. I know that there are a number of day program providers that had ceased services during the pandemic. Whether or not they will be able to reopen and rebound, and those were the organizations that provided day or employment services exclusively. So there's definitely some exposure there. As I mentioned, we know that the states are already asking the state agencies for projections in double-digit budget cuts. I'm aware of at least 5 states that are postponing their FY21 budget decisions until the second quarter or later in the first quarter to see if there is additional federal relief coming. So I think that they are all bracing for significant revenue shortfalls. And we know from experience that oftentimes Health and Human Services carry at least a significant piece of those shortfalls. So time will tell what actually happens, how it all shakes out in the end. But I do see, and what we have started talking about with some of our colleagues at AADMD and at NASDs, those entities that we partnered with in our first briefing, is dialogue around how can we use this situation, this pandemic, as a springboard to really try to reshape our service delivery model, be it on how services are actually delivered and how they are funded, how that is structured at the federal level and at the state level. So I think we are going to enter a period of a lot of change. Some people think that because of the budget shortfalls anticipated, that states are really just going to hunker down and just try to do what they do with less money. And then others of us think that this is an opportunity to work with our state and federal partners to really critically look at how we can reshape the services that are delivered and do so in a person-centered way.
Thank you. Do nonprofits get the funds to help pay for the enhanced pay to DSPs?
Well, again, that varies. So as I said, there were only a few states that that guaranteed or offered retainer payments or hazard payment to providers. Many providers did so, at their own expense. And with the CARES Act, last week we had the provider relief tranche was released, and that provided for, I think it was about $15 billion in funding for Medicaid providers. Now that's all providers. It's not just IDD. It's physicians. It's general MDs. It's speech therapists. It's any Medicaid provider in good standing would be eligible to access some of that $15 billion. So there's a rather lengthy process to apply for it, and there's a lot of questions about exclusions and who can and who can't apply for it. But assuming that most organizations will be able to tap into that provider relief fund, those are the dollars that will come directly from HHS to the service provider. So ostensibly, it will help them to cover some of these enhanced costs. But it's yet to be seen if anyone has actually received those funds yet, and how that will all flow. So probably in the next couple of weeks, we'll know a lot more about that process. So to answer, real long answer to that question, providers will get some funding toward those expenses like hazard pay and retainer, helping to keep the doors open, but it's undetermined just yet how it's going to unfold.
Thank you. I've also posted a link to the full report in the chat box as well. We will have the link when we share the archived version of this webinar as well. Another question for SE providers who do job coaching at consumers' work sites. What are you hearing about whether companies will allow them on the premises? This will be for a few weeks while consumer is learning the job.
Mm-hmm. I haven't heard that employers are not allowing support, job coaching supports on site with an individual. What I have heard more readily is that people are trying to use the remote technology to do that. So whether they're checking in with the individual at the beginning of their shift or partway through, I think a lot of organizations are testing that out, but specifically to your question, I've not heard about employers prohibiting that, but I couldn't answer that definitively.
Another question, any data on whether the support has meant that parents could continue to work?
Can you say that again, please?
Any data on whether the support has meant that parents could continue to work?
No, not specifically. We did not evaluate that as part of this project with regard to if people are not going to day sites, but parents or caregivers are having to return to their own jobs. I don't have data on that at this time, but that would be an interesting thing to take a look at.
Thank you. One of our attendees said that they actually have a few coaches going back to work sites with clients, just as a comment. I also had a question. So where do you go from here? Are there going to be any follow-up surveys? What's your plan for the next 6 to 12 months?
So some of the work that we have already started is breaking down the state level data. I've done some analysis for about a dozen states that have requested such to supplement their advocacy within their own state. So what I'd really like to do is start to look at those trends and how that shakes out. And then on a parallel path, last week we held a forum for members where we asked people to just kind of, talk about different experiences. So we had a couple of states talk about, now that everything is fully open, how are they managing it? How are they keeping people safe? For those states that are not yet open, what does that look like? What are some of the decision points? How are we moving into the new normal? So how are we making systemic changes that are a direct relation to COVID-19? And then one of the other things we looked at is how is this pandemic really forcing a paradigm shift? So at this point, we've got a good amount of anecdotal information from the states about these experiences, and I'm sure we will do more work on that front, although we don't have a specific survey identified at this time. Or I should say a formal survey identified.
Another question came through. Do you know anything about the transportation services?
Well, transportation is one of those service areas that is going to be really challenging. I mean, transportation has always been, for those of you working in the sector or really closely familiar, transportation has always been so difficult. You know, it's so costly, it's so inefficient, it's so underfunded. And then now, as either states are requiring or providers in an abundance of caution are looking at changing up how they assist people with transportation, it's going to be really difficult to maintain social distancing, to get people where they need to go when they want to go there. Again, I don't have, you know, a specific kind of example or reference point, but I can say that I know what I hear from both residential and day or employment types of programs is that transportation is probably one of their biggest hurdles.
Thank you. One of the attendees is commenting we have had a huge increase in behaviors and mental health issues, along with many increases in medications and adding more BCBAs. Are you going to look at what this has done to the mental health status of those we serve?
That's a great question too. I know that there is, you know, across sectors, a lot of conversation about the emotional impact of the pandemic. At this time, we don't have a plan to study that, but I'm sure someone in our sector will likely do that. You know, you think about
data? Oh, go ahead, sorry.
I was just going to say, we think about the impact it's had on all of us who, you know, probably have good support systems, good communication systems, good, you know, good ways to kind of respond and adapt to problems, and how stressful it's been for people who, you know, are neurotypical. And then when you think about people that have communication struggles, emotional struggles, that maybe don't have a real strong social network, clearly it's very stressful for folks. So, you know, we're hearing that from all corners.
Any data in relation to the size of CDS program at this time?
Any data on the size of community day supports as far as limits on numbers of people? I'm not quite sure what the question is asking.
All right, I'm going to wait. Yes, the size of the programs.
You know, again, I think that varies state to state as states are in different phases of opening. There are limits on group sizes. Certainly that is going to affect congregate day sites. What I have, again, heard anecdotally is some providers saying, if I previously operated a day service or a community-based day program for 100 people, and now I can only have 30 people or 25 people, you know, or 15 people come in at a time, it is not financially feasible to operate. So I'm either not going to open, or I need to think of a very different way of providing that service. So again, you know, I think, as I said, not to be repetitive, but so much of organizations' responses vary according to what's happening in the individual states. I think as we start to move away from the intensity of this pandemic and we can start to reflect back and look at trends, it'll be really interesting to see, you know, to talk about what we've learned and what have been the best practices that have emerged. You know, I think we will have a really interesting and robust conversation in 4 to 6 months.
Thank you. One of the goals was to provide additional information to the federal government regarding more funding based on these findings. Was there any projections and funding requests based on this data?
Well, we hosted a virtual congressional briefing and presented this report to congressional staffers. And we have included this information in letters to HHS, letters to congressional leadership, letters to CMS. So we have been sharing this information and the urgency that the service organizations are experiencing. And I think we have gotten really good support from Congress on this. It took HHS to figure out the pathways to distribute funds, because doing so is completely unprecedented. These organizations, particularly Medicaid service providers, have always worked through that state-federal partnership and through those pathways. Never have we ever received fundings directly from HHS. So it's been a real challenging process to navigate for everyone. But I certainly would like to think that our data certainly helped to bolster our advocacy, and I think it really helped to inform Congress, particularly congressional staffers who are, kind of laying the foundation for a lot of the policy work that feeds legislation and is in response to legislation.
Thank you. Another question, what time parameters are they able to bill with technology?
Are you asking specifically as it pertains to the Provider Relief Fund, or are you talking about regular everyday billing?
We will wait for the person to clarify that. I'm not sure.
Okay.
So we'll see.
Yeah, I think if you're talking about routine billing, that will probably happen in a manner that is consistent with what you experienced in the past. If you are talking about the Provider Relief Fund that's coming to Medicaid providers from the CARES Act, organizations have until July 21st to complete their application in the HHS portal. And what we don't know yet, but what we think will happen, is that HHS will release those funds on a rolling basis. I guess that's what we're hoping, and that they are not going to have to wait until mid-July and until that application window closes. So if you're asking about the relief funds, we don't know, but we know people have to apply by July 21st.
Another question for provider relief form, what does that entitle for speech therapy, and could ICF apply for it?
Any Medicaid provider in good standing that has not received funding from the Medicare tranche, or does not that does not also bill Medicare, is eligible. So as we understand it, ICF providers are eligible. An individual provider of, speech or PT or psychiatry to Medicaid recipients, as we understand it, are able to apply for those funds. But if it's a speech therapist that works for a provider organization and is not in private practice, it would be the organization that applies for the funding.
Another question, will DSPs working in day programs providing personal care qualify for hazard pay?
It's not a matter of qualification. It's really a matter of if the organization they work for has been able to find the funding to do that. So early on in the pandemic, we advocated that the states, that governors classify direct support professionals as essential employees. And we did that because we knew that we would need our staff to be able to get to work and be out and about as states were basically locking down and people were expected to quarantine. So the notion of essential worker, many states did include direct support staff in that classification. I can't say that all did. I don't know that all did, but many did. But as it relates to hazard pay, that is not something that has been expressly provided for in any of the 3 relief packages yet. I will say that with regard to the 4th COVID package that we expect will start to be worked on, well, we know that the House passed the HEROES Act several weeks ago. The Senate has not taken it up yet. And from what we're hearing, House and Senate will not start negotiations on that until after the 4th of July recess. But what I can say is that in the HEROES Act, there were a number of provisions that were designed specifically for HCBS providers. So there was the notion of an additional FMAP increase that would be directed specifically for our sector and not able to go into the general fund. And then there were a number of other provisions that really sought to funnel funding specifically to our sector. So if that makes it through the Senate and House negotiations around the HEROES Act, then there, I believe, is a provision for hazard pay specifically, but short of that, there is not. And it is really at the up to the providers, up to the organizations, if they have the resources to do that.
Thank you. We have a couple of more minutes for a couple of more questions while I'm waiting to see if anyone is going to ask any. I do have one. What needs to be done from the advocacy perspective as we are kind of trying to get ready?
That's a great question to end up. That's a great question. So what we would ask is that you work with your local associations, whether it's an ANCOR affiliated association, like a state provider trade association. There's one in almost every state. There happens to be 2 in Illinois, if a lot of the callers are from Illinois. Or to work with your local ARC chapters or UCP chapters, and to reach out to your Senate and House delegates to tell them that they need to support provisions like those embedded in the HEROES Act to provide funding for staff, for wages, for recruitment, retention, for all of those elements that are outlined in the HEROES Act. And that information is all on our website. Again, I'd encourage you to go to ANCOR.org and to look at the Forgotten Faces campaign, and to also review our action center there's a lot more detail about all of this there, and to use your voice to advocate.
Thank you so much again. Someone was asking, is there a link for that resource that you just mentioned?
Yes, just go to ANCOR.org, and on the landing page, you'll see the Avalier report that we referenced here. You'll also see on the landing page a link to the Forgotten Faces campaign, and also embedded there, I believe, is a link to our advocacy center. So just go to ANCOR.org and look around. There's a lot of information, and I'm happy to send those additional links to Yasmina to include with the information that goes out.
Yeah, thanks. I did find the report, and then I just shared Forgotten Faces. But yes, everything is on the front page. So so on the landing page. Thank you, Donna, again so much. This was extremely sobering and informative, and thank you for sharing this. We've had over 500 attendees, and we had almost 1,000 registrants today, so a lot of people have interest in hearing. about this information.
Great. Well, thank you very much. Thank you very much. And my contact information is here on the last screen. If anyone has other questions, please don't hesitate to reach out to me.
And we will, again, share the recording, the PowerPoints, and we will add all the links to the reports on our YouTube channel and our HealthMatters program website. So thank you again. We're to the hour. I will stick around to see if there are any more questions, but a lot of thank yous are coming through. And have a great rest of the day and week. There are some people are asking about participant certificates. We do send out thank you for participating email, and a lot of people have used that as a proof of attendance, but we do not issue certifications for the attendance. Again, thank you so much, Donna.
Thank you very much. Thank you, everyone.
Thank you. Bye.